And what happens is the stress in the chronic coronary syndromes, the stress myocardial perfusion imaging still remains to be the ideal gatekeeper, especially for the invasive coronary angiography, even after because it has been there for 4 decades. A lot of studies have been done, a lot of risk assessment and appropriate utilization has been done on both men and women. In fact, STREX MPI helps to identify the low and low intermediate risk obstructive coronary artery disease, subclinical atherosclerosis, inducible ischemia, and also the anatomical imaging methods like CT coronary angiograms and MR coronary angiograms. Along with that, it gives a lot of valuable information regarding the prognostication of the patient. It can be safely done even in young patients who have high pretest likelihood, especially in diabetes and also hypertension and all, with a strong family history of coronary CAD, and allows periodic follow-up, especially after which provides and adds incremental information regarding risk stratification at a low cost. I am just showing this because there are non-nuclear medicine physicians, non-nuclear medicine familiar cardiologists are also there in the audience. And these are some of the equipment that we are using in our routine practice. This is the one which is a general equipment, and this is a dedicated cardiac equipment with solid state detectors. And at the same time, the way things are improving over a period of time, the equipment is also evolving, the science behind it is also evolving, and the radiopharmaceutical understanding is also evolving. Commonly, we are using thallium ions. Thallium ions resemble potassium ions that migrate into the cells through the sodium-potassium ATPase. We also use sesame B, which gets sequestrated in the mitochondria, and also tetraphosphine. These are the 3 things which are using for our routine clinical practice. There are a lot of new traces that are being evolved. And what happens is they'll be slightly better in the sense it causes 8 times uptake in the myocardium, has a very rapid clearance from the background soft tissue and the liver and the non-target organs, and also prolonged retention of tracer in the myocardium. All these added benefits are there, but then it is yet to come into conventional clinical use. This is the way the images are being depicted. The short axis, the standard representation, this is short axis, vertical long axis, and horizontal long axis. The perfusion defect is what is seen like this. And the 3-dimensional image we construct into a standard sounding segment bullseye plot like this. And we can give a scoring where 0 is a normal perfusion and 4 is a no uptake. So anywhere between these two, all these are added up and we arrive at a score and come to objective information. What happens is, it's a real challenge of late in the developing third world and especially in the countries related to upper middle income group and the lower middle income group. There is a progressive increase in coronary artery disease as per the World Bank data. In the higher income group countries, there was a steady increase up to probably 2015, and then slowly, then it is increasing now. As a consequence, what happened? There is increased demand on the Cath Labs for performing the invasive coronary angiogram, because straight away our patients are straight away sent to the Cath Labs and there is increased pressure. As a consequence, the quality of performance in the Cath Lab is compromised in terms of which can be objectively measured in terms of quality indicators, whether it is an in-hospital mortality or a 30-day mortality. It can result in unplanned CABGs or incidental non-obstructive CIDs, missed door-to-balloon time, wrong patients. It can be due to elevated STMIs, radiation exposure, on-time arrival of patient with Cath Lab error, medication errors, and cross-functional teams, vascular access. It can lead to adverse cardiac events like coronary perfusion, cardiac tamponade, stent thrombosis, and neuronal complications, radiation risk, bleeding. All these things can happen. As a consequence, there are a lot of checks and measures in order to ensure that the best of quality is done in the Cath Lab, and the best patients are giving the maximum. Patients are receiving the maximum importance. What are the ideal qualities of a non-invasive gatekeeper? In a non-invasive gatekeeper, it helps in avoidance of unnecessary procedures by performing 1 or 2 tests. Accurate identification of clinically exclude insignificant disease where the revascularization will not be of any potential benefit. and also it can provide optimal strategy. It results in few false positive tests, and at the same time avoid excessive false positive tests, so that that can provide low post-test positive results. And also the tests that decrease the increase these tests decrease the rate of invasive coronary angiography while increasing the diagnostic yield in the presence of real obstructive coronary artery disease. Cardiac, as we have all discussed in earlier speakers also, it still remains to be the ideal gatekeeper, as the inherent ability to identify the patients with known CAD because of its non-invasiveness, objective, precise, safe, easily reproducible, and also become an invincible tool in the evaluation and management of chronic coronary syndromes. When we get a normal scan, what does it guarantee? It says that in a study done over about, in 4 subsequent studies done over about 11,000 patients, it says that when a normal MPI is obtained, it provides a data of event-free survival. Some studies say that it is up to 2.8 years of event-free survival. And in the presence of other comorbid conditions like increasing age, diabetes, hypertension, etc., and all these things have a definite impact. And this is a study which shows that when there is a younger individual in a female study, when there is a normal study, this is what it happens. And when the older individual of 80 years old, the event-free survival is less. So, the warranty periods depends upon the other comorbid conditions also, not just because it is a normal perfusion scan. We can see that there will be event-free survival. In women with coronary artery disease, a lot of interesting studies have come up of late. And it says that in stable ischemic heart disease, even with 70% luminal narrowing, epicardial vessels in performing a myocardial perfusion study helps in reducing the unnecessary and potential diseases. It helps to reduce the radiation exposure what the patient gets in a cath lab, reduce the cost in the healthcare systems, and there is a lot of developments, especially in the solid state detectors, better software, noise reduction, recovery, resolution recovery. So many things are happening in the modern equipments. And exercise tests will also be more physiological and is preferred in women. And there is a most famous women's study which says that the people with patients with intermediate likelihood are maximally benefited. In a study, more than 22,443 patients, a normal stress says that the cardiac event rate is only about 7% only. So this is a very useful test, still remains to be useful in screening for acting as a gatekeeper. And your gatekeeper, in the sense, it need not be a gold standard. It says that it can take care of the essentials. In combination, we were discussing about it earlier also by Dr. P.C. Molaria. A single modality cannot give the entire whole set of information. When we are able to combine with anatomical information as well as the functional data, the lot of useful in the sensitivity and the specificity of the information will be more reliable. As a consequence, scientific forums like the SNMMI, European Association of Nuclear Medicine, all these things have started evolving guidelines how to manage patients with intermediate risk. And when we combine this anatomical as well as the functional modality, we'll be able to understand very clearly what will be the major adverse cardiac events that can happen during the follow-up. So to conclude, what happens is the myocardial perfusion spect is very helpful in following up the patient management decisions in terms of risk assessment in patients with intermediate and high likelihood of coronary artery disease, in selection and modification of therapies in angiographically benefited coronary artery disease, identification of culprit lesions in borderline CAD prior to coronary interventions, risk stratification of post-MI patients by doing pre-discharge for stress and pharmacological testing, evaluation of patients following thrombolysis, pre-discharge evaluation of patients with unstable angina, risk stratification especially in elderly patients and patients with congestive heart failure with severe LV dysfunction, evaluation of patients with treatment modalities for CAD, especially with whether which is appropriate, PCI or CABG or optimal medical treatment, how to individualize the treatment protocols that can be very helpful in this. This stratification with non-elective, non-cardiac surgeries, and This enables selective referrals to invasive coronary angiography based on high-risk findings in patients with mild to moderate, and when medical management outcomes will be less helpful and more expensive in the longer run. So with this, I like to conclude my lecture. In fact, a lot of studies are being done, and when we go into the details, because of the 10 minutes time interval, time constraint will not be sufficient.
Thank you.